Continuing with the fungal infections, now we will talk about candidiasis. First is oral candidiasis. It can be white as well as red. The white one is the pseudomembranous type and the chronic hyperplastic type. The red one is the atrophic candidiasis. It can be acute as well as chronic. The acute one leads to an antibiotic sore tongue and the chronic one leads to denture mouth. The second is candidial intertrigo. The site is intertriginous area. It is seen when there is a lot of sweating in this area and it leads to red, macerated, that is soft plaques, and satellite lesions are seen in the periphery like pustules. Satellite lesions are also seen in the BT types of leprosy, so this is an important point to remember. Now we will talk about the third one, that is candidial balanophthitis. It is seen in patients with uncontrolled diabetes mellitus. Swelling of the prepuce is seen. Radial fissuring of prepuce is seen. Fourth is candidial paronychia. Swelling of the nail fold is seen. It is seen in wet workers or the detergent users when there is excessive use. The most common organism for the acute one is Staphylococcus aureus and for the chronic one is Candida albicans. Investigations to be done in candidiasis. First one is preparation of KOH mount. The yeast form and the pseudohyphae of the fungus can be seen. Sapura's dextrose occur. Creamy white colonies are seen. Germ tube test or the Renault broad phenomenon. Candida intubated in human or sheep's serum at 37 degrees Celsius for 3 hours and the germ tube forms. A filamentous outgrowth from the yeast is seen. Now we will talk about dermatophytosis. Superficial fungal infection of the keratinized tissue, that is skin. Sites are stratum corneum of the skin and hair and nail. These three, that is the keratinized tissue, stratum corneum of the skin, hair, nail. Genera, Microsporum, it is seen in skin and hair. So over here we have M, so it is absent in N. This is a mnemonic. M is absent in N, and epidermophyton, it is present in the skin and the nail and it is absent in the hair. ठीक है ना? Then trichophyton, it is present in skin, hair and nail, all three. Tri, present in all three. Region-wise distribution of dermatophytosis. We have tinea capitis, involvement of hair shaft. Non-inflammatory type and inflammatory type are seen. Non-inflammatory type is the non-scarring alopecia causing tinea capitis and the inflammatory type is the scarring alopecia causing tinea capitis. In this one the types are black dot and the grey patch. In this one the types are Favis and Chirion. Tinea capitis non-inflammatory type. We have the black dot and the grey patch. Black dot fungus goes into the hair. Endothrix, produced by Trichophyton tonsurans and Trichophyton violaceum. Non-fluorescent on wood lamp. This fungus will be non-fluorescent on the wood lamp. Hair follicle becomes weak and the hair breaks off, resulting in multiple black dots. And the grey patch, which is known as the ectothrix, fungus is present around the hair. Okay, it covers the hair. It is produced by Microsporum canis. It is blue-green fluorescence on the wood lamp examination. Next we have tinea capitis, inflammatory type. First is Favis, second is Chirion. Favis, endemic in Kashmir. Yellow cup-shaped crusts are seen which are known as the scutula. Trichophyton schonleni produces it. Dull blue fluorescence is seen on the wood lamp examination. Chirion, severe inflammatory type, thick crusting, matting of hair. This is present. It is seen in children. Boggy scalp swelling develops and the hair, they become easily pluckable. regional lymph nodes get enlarged. Tinea capitis, epidemiological data. The most common cause of tinea capitis in India is Trichophyton violaceum, and the most common cause of tinea capitis in the West is Trichophyton tonsurans. Most common cause of tinea capitis in the world is Microsporum canis. Now let us talk about the treatment of tinea capitis. Drug of choice overall is griseofulvin. The mechanism of action of griseofulvin, it binds to mitotic spindle and produces the metaphase arrest. The drug of choice for Microsporum species is griseofulvin again, and the drug of choice for Trichophyton species is terbinafine, as it inhibits the scoline epoxidase. Now let us talk about some other dermatophytosis. We have tinea faciae, which is present on the face, tinea barbae present in the beard area, and the tinea manum, which is present in the palms. Tinea ungueum, and the onychomycosis. This is yellow and thick nail plate. Subungual hyperkeratosis. Tunnels are present. Most common type is TLSO, distal and lateral subungual onychomycosis. PSO, proximal subungual onychomycosis, is seen in HIV infected patients. On QH, we can diagnose this infection. The fingernails, 6 weeks, oral terbinafine. What is this? In case of infection of the fingernails, we give oral terbinafine for 6 weeks. In case of toenail infection, we give oral terbinafine for 12 weeks. Tinea corporis, that is infection of the trunk, involves the glabrous skin, that is the non-hairy areas, except the palm, sole and the groin. Tinea cruris, or the dhobi itch or the jock itch, it is present in the groin region. Eczema marginatum, you need to remember this term. Athlete's foot or tinea pedis. Ringworm of the foot is another name. Trichophyton rubrum causes it. The most common site is the fourth toe web space.